The onset, I would just like to thank the Youthful chapter of IRSI for giving me this opportunity, Dr. Himanshu sir. I am Dr. Varun, and after that compelling argument that Dr. Haroon made regarding the judicious use of lubricants, I'm going to give my two bits about the hit and trial methodology on how I use the lubricants or how we can use them. A couple of disclaimers. I have no financial disclosure. My topic is such that doesn't allow any room for that. And I would like to make it clear that my argument only applies to the common empirical use of the lubricants in practice and not to specific severe dry eye cases, because that kind of makes this argument redundant. Also, I've kept my talk very simple. It's not going to be as detailed as Dr. Haroon's, but I've just tried to push my point, keeping touching on few basic ideas. So I follow this theory that in theory and practice are the same, but in practice they are not. What Dr. Haroon just showed us made absolute sense, but it made theoretical sense. A lot of the times we see that the theory does not directly apply to what we see in practice. But obviously, theory and practice have to go hand in hand for complete learning. Now, coming to the meat of the matter, is lubricant use really as simple as 2 plus 2? I'm going to try and prove it is not. I'm going to use the concept of the ocular surface microenvironment, the multifactorial nature of the OSM, and how these different variables have to combine in a very delicate balance to maintain the normalcy of the OSM. We begin with osmolality. So we all know that the isotonic eye drops are the best, and the normal tear has an osmolality of between 290 to 310 milliosmoles per liter. Also, the osmolality of the same person's tear film is very dynamic. It changes with temperature, the surroundings, time of the day, etc. Generally, it was always considered that hypoosmolar drops were good and hyper were bad. But now there is research to show that too much hypoosmolality can also cause some amount of microcystic corneal edema. Now, on one hand, we know that osmolality is dynamic of every tear film of every person. On the other hand, I have this screenshot of the Excel sheet I got made yesterday. This is the range of osmolality of all the available lubricant eye drops in my OPD. And we can see that the range varies from almost 270 to 80 to 330 to 350 milliosmol per liter. Now, it only begs to reason that with all the videos that Dr. Haroon pointed out, we find one eye, it is very unlikely that you'll hit the bullseye with the first drop with such a huge range on both sides. So it is only natural that we might have to try multiple drops till we hit upon the correct combination where the drop's osmolality matches the patient's tear film osmolality. The second important point is the pH. This, again, like the osmolality, has a range from about 6.89 to about 7.45 and is dynamic, varies with the time of the day. Depends whether you wear contacts, the CO2 levels a person has, especially with the usage of mask these days. Now, the big thing with pH is that a mismatch in pH is going to cause intense stinging immediately after installation. Of course, there are buffers in the drop which will neutralize the pH in a few seconds, but that initial stinging response is going to govern your long-term compliance. And if there is no compliance, then the whole treatment becomes pointless. Again, like osmolality, it is not practically possible to measure the pH of every patient that walks into your OPD, also to monitor the diurnal variations. So hit and trial method is the only way to move forward. I'm not saying that you just go randomly trying drops. We can apply a concept which is in combination with what Dr. Haroon said. There has to be a method to the madness. But even in the subcategories, it is not very common that you hit the bullseye with the first drop that you use. You have to try different sorts of the classification of the drops to finally reach the perfect drop. This again is a range of the pH of the drops that are available in my OPD. And again, we can see there's a huge range from 6.29 to almost 7.4 to 7.5. Again, proving my point that the hit and trial method has to be the only thing we revert to if we don't get it right the first time, which we generally do. Preservatives, something which Dr. Haroon has touched on very nicely. My point, all preservatives have different qualities. Yes, we should avoid benzalkonium chloride, but you never know. Some patients might be allergic to SOC, some patients might not be, some patients might tolerate BAK, and so on. And we will not know which patient is reactive to which preservative unless and until we use that. Economics is very important, especially in tier 2 and tier 3 cities where I work. An eye which might be suitable for a drop, which might be suitable for the tears, might not be suitable for the pocket. And that is very important for long-term compliance. Also, to some extent, it governs the preservative choice. You see, preservative-free drops or UNIMs cannot be used in a certain strata of society which can't afford, that many drops for that longer duration. So here we have to try, drops with SOC or drops with vanishing preservatives. Also, there are certain people who don't have access to refrigeration at home. For them, we have no choice but to try drops with BAK preservatives, which have a more robust protection of, a range of temperature in which they keep the drops healthy. So yes, economics does play a role in choosing the drop as well. And then comes the concomitant treatment, like Dr. Harur said, that purely lubricant treatment is not enough to treat dry eye. Now, what we have to keep in mind is a lot of patients who walk in have already been using antibiotics or require antibiotics for blepharitis and such. They might require antihistaminics, anti-inflammatories, and so on. Antibiotics change the microflora. Microflora itself has a big role in maintaining the normal OSM, and then that disturbance has to be countered by a lubricant. Along with that, the other drops have their own pHs, have their own osmolalities, have their own preservatives. So that kind of creates havoc in this very delicate balance, and the lubricant has to be titrated accordingly. In conclusion, I would just like to say that all eyes are different, and so is the chemical and physical composition of every individual tear film. Even if we were to judiciously use the absolutely correct eye drop, but with a pH or osmolarity that's different from the patient's tear film, or a preservative that did not suit the patient, or economics that do not fit with the patient, the end result would never be satisfactory. Eventually, it's going to be the hit and trial method that we're going to rely on till we hit the most appropriately suited lubricant for each eye, and only then can we give the patient the best possible. These are my references, and thank you very much.